Good afternoon, ladies and gentlemen. The webinar is now beginning. My name is Steve Love, President and CEO here at the Dallas-Fort Worth Hospital Council, and we continue to have our educational webinars, and we thank you so much for joining us today. As you know, we have hospital members, but we're also delighted with our associate members, and we have Argos Health with us today, and they're hosting this webinar on something that really is a very important topic, dealing with out-of-state Medicaid claims. Argos Health is a revenue cycle partner. They deal with complex claims, and their business deals with billing and resolving claims. And they pride themselves on managing those challenging accounts so that they can help maximize appropriate reimbursement for healthcare providers. Today's topic is out-of-state Medicaid claims, and we have two excellent expert speakers to provide a good overview of dealing with out-of-state Medicaid claims. And this could be problematic or an opportunity, if you will, for North Texas hospitals. Our two speakers today are Kirby Yon, a Senior Vice President at Argos Health, and Dee Germroth, a Senior Vice President, Medical Solutions at Argos Health. Kirby, responsible for developing all good professional services and led the day-to-day operations as Chief Operating Officer. In 2017, All Good Professional Services was acquired by Argos Health. Kirby now leads Solution Strategies, focusing on client partnerships and business development. Dee was the founder of Cade Solutions, which was acquired by Argos Health in 2019. She has over 25 years of experience in healthcare receivable services, specializing in Medicaid state plans. And she works closely with clients developing their PFS systems, which allows the optimum claims processing and improved revenue. In fact, Dee and I were chatting briefly before we began this webinar, and I actually remember meeting her at the American Hospital Association when she made a presentation in the past. So we really look forward to hearing from these two experts. So ladies and gentlemen, I present to you Kirby and Dee.
Thank you, Steve. And before we get started, I'm just going to check in. Dee, you still out there?
I am still here. Can you all hear me?
So it shouldn't be any secret to anybody that's listening to the webinar. Dee and I are actually almost as far away as you could be from each other in the country, but with the beauty of technology, we're able to host a webinar that everyone right in between us can see. I'm actually in Georgia and she's in Arizona, but we've gone over it, and luckily our webinar isn't too scripted, I'll say, so we should be able to feed off of each other pretty well and hopefully get some really good information out to everyone. And Steve, certainly we thank everybody at DFWHC for saying, hey, y'all want to come on and do a webinar on what is a small volume of claims, but can just really be a big headache. So without further ado, let's get to flipping through some slides. I don't remember, or I don't know if anyone on the webinar remembers that Argos helped host a webinar with DFWHC probably, Steve, I would guess maybe a little over a year ago now, when we talked about VA claims. And I think I actually used this same slide. And interestingly enough, I've used this same slide in almost every presentation I've ever done for about 9 straight years, because as everybody on the webinar knows in healthcare, I don't know if this slide has ever changed in what we deal with on a daily basis. It seems like we've always got these two doors to walk through, especially now with what you read every single day in the headlines. And I won't even go into the coronavirus thing. I was talking about the headlines that were pre-coronavirus. I want to start by just giving a little bit of background on who we are. Steve gave a little bit, and I promise not to make anything too terribly salesy or spend too much time on, who and what Argos Health is. But I do think it's important for everyone to see we focus only on 4 types of claims. And you can see from the middle of the slide there, Argos Health is the product of 3 companies that have come together, each with at least 10 years of experience in their space. And having Dee on this webinar, to me, is just a great benefit to everyone that's listening, because you can see there the company she helped found that happened back in 1997. So we're really fortunate to have someone on the webinar with us that just has years of experience. So I don't think there's anything Dee hadn't seen. Dee, could you concur with that?
Well, let me just say, I'm really such a baby. I, don't want to claim that I've been around that long. So, you know what? Over the years, we've seen lots of regulations change. Some have stayed, some have come and gone. So we just keep changing with the flow here, and we're really good at doing that.
Awesome. Well, we're lucky to have you as part of our company and also on the webinar. A little bit of, again, background. Last year, we were excited to receive the #1 ranking by Black Book. I don't know if anyone on the webinar knows what Black Book is, but Black Book isn't something that someone like me as a vendor gets to know about. I don't get to pay a subscription to be part of Black Book and then hope that a ranking comes out. The day that everybody learned about our #1 ranking in Black Book is the same day that I learned about it. So it's anonymous sort of feedback, and it's not one of those things where you're paying to be a member, where you're basically just buying your advertising. So we were just glad to receive the ranking, and we were extremely satisfied that out of the 18 things they rank you on, we received the #1 ranking in 9 of those categories. So that's a pretty big deal when you can get half of them as the #1 ranking out of the 18. This shows you where we're located. Again, I'm sitting in Augusta, Georgia. Dee's over there in Arizona. We've got an office in Hudson, Ohio, and then corporate headquarters is right there in the great state of Texas in Dallas. For some reason, it's a really big deal when you can say you've collected over $1 billion for your clients. So we have collected over $1 billion for our clients. We're in over 200 hospitals, but let's focus on the last bullet point there, because it kind of leads us what we're going into. It is a well-known fact that the complex claims space we operate in only account for about 3 to 5, maybe up into the 7 to 9% of your overall patient population. We get it. It's never going to be a high volume thing, but for such a low volume, it is a tremendous headache. And the headaches don't just exist in the out-of-state Medicaid space. The company I helped found that did MVA, TPL, and VA work, the headaches exist, and certainly in the comp space, the headaches exist. So we're excited that we kind of stay in our lane. We don't try to be the big box revenue cycle vendor. We like our complex claim space, and we like the little niche that we've created. So we did say that as part of the webinar, we were going to go over 4 things, kind of 4 learning points. And when we were going over, well, what are we going to talk about? I'm fairly new to the out-of-state Medicaid space, but what I found once we started peeling back the layers of the onions of, what's going on with these out-of-state Medicaid claims, it's interesting to realize that we are dealing with federal issues, but we're talking about state plans. And what I mean by that, and you can see from my bullet points, is that we're experiencing these nationwide overarching / federal requirements that are being pushed down, that are being adopted at the state level. And you see that some, but you usually don't see it in things that are administered by the state, like Medicaid. So these requirements are part of the Affordable Care Act. So they're just a byproduct of what was signed into law, and now we're seeing it come to fruition. And there are absolutely good intentions that exist, but some of those requirements that are in the ACA that now relate to Medicaid when it crosses straight lines have certainly compounded the claims process. And if you were to take the fact that I only started really focusing on out-of-state Medicaid claims about early summer 2019, it has gained a lot of steam just since then. So it's kind of been snowballing. There, every single phone call that we are on where we are saying, hey, hospital, would you like for us to handle your out-of-state Medicaid claims? Without a doubt, the number one hurdle is provider enrollment right now out there in the marketplace. And I think that would hold true for everybody that's on the webinar. We have had some phone calls with some folks in Texas, and they certainly brought that up. So it's important to realize that while that used to not be the case, there are now only 19 states in our nation that don't require physician enrollment. Well, that's changed a lot over the past few years. And according to ACA, by the time 2 more years are up, those 19 are going to have gone away. So this facility and physician enrollment, that is just the number one hurdle and kind of the number one thing you hear about of that's why I can't get the claim paid. It has become an increasingly large problem. Now, what's interesting is in order to get those facilities and physicians enrolled, most of the time you run into having to give some board information, and a lot of hospitals get some pushback from their board. Interestingly enough, the information that's being asked is no different than what's required for you to be a Medicare facility. So the hospital is already providing it. It just seems that all of a sudden when it comes up on a one-off claim, or the claims that don't make up such a large volume, these false red flags start to be waved. So nothing's being asked more than what's needed on your Medicare applications. So I hope that helps to ease a little bit of the listeners' apprehension around, oh, I'll never get that done. There's certainly some ways to go about it where you can get this information a little bit easier. Sometimes the last little bullet point you see on there, interestingly, when a third party is involved and they're asking for that information, we've found that, well, sometimes those board members and the physicians they give up that information easier, or they seem to have less of a problem with it. Now, why is that? I don't know. Maybe it's just confirmation that someone from the outside is saying, oh no, we've vetted the fact that that information needs to be provided. So, what's going on federally, this is a huge, huge hurdle to try to overcome. Dee, did I miss anything?
Nope. I think you explained that very nicely.
Okay. And as I'm sure everyone that's listening, if you've been on any of the DFWHC webinars before, I believe it's going to be tomorrow. They're going to have this webinar out so someone can listen and look through. So I put a link out there, and there's going to be some links later in the presentation. That way you don't have to try to write that down or type it down real quick. You'll be able to go back to that and read some of these articles that we've found and are posting out there. They're also available, a lot of these articles, through our Argos Health LinkedIn account. So we try to keep our LinkedIn account more along the lines of news you can use. And there's certainly some good out-of-state Medicaid posts we've had out there lately. Now, the second kind of overarching thing we were going to talk about today was, how big could a facility's out-of-state Medicaid problem be? Is it something that really requires your attention? Or, are we having this webinar and we're going to talk about something that at the end of the day, it really doesn't matter? So what we typically see when we go somewhere is that it's hard for a facility that hasn't focused on out-of-state Medicaid to really quantify what is their out-of-state Medicaid problem, especially when you start to ask the question of, well, how much revenue do you think you've lost because of whatever you're doing? And by whatever I'm doing, we're going to get to that on the next slide. So quantifying the opportunity or the problem, but let's call it opportunity so we can keep a positive spin on things, it is usually something that's the first step of, oh gosh, I might really need to focus on this. And you have to ask yourself, well, why is it a problem to even figure out what the opportunity may be? Well, there are a couple of things we've found, and the first one is it could be just as simple as the facility has never really tried to establish an out-of-state Medicaid financial class, insurance plan, coding, et cetera, whatever you want to call it in whatever EMR system you're working in. If you don't currently do that, I would highly advise you to go ahead and just get that information into one little bucket. That way you're able to track, well, how bad could my problem have been in the past, and how good is the solution we have moving forward? Now, historically, when we go into a place and say, hey, we'd like to do this work and we'd like for you to tell us what's your out-of-state Medicaid claim volume, we see answers on the last bullet point of this slide, such as, I can get it, but it's probably not going to be accurate, or I think I can get it pretty close, but it's not going to be exact. And to us, we ask the question, well, wait a second. If you needed to tell me right now, how many Blue Cross Blue Shield of Texas claims do you have open, and what's their dollar value, and what's their potential reimbursement? I'm going to guess that just about everybody on the phone call could get it down to within a couple of claims difference or within a couple of dollars difference. But out-of-state Medicaid usually doesn't get that attention. Now, you have to ask yourself, why is this? So what we've found in the past is figuring out the claims volume for out-of-state Medicaid usually starts with the hospital saying, well, I'm just going to run you a report of all my Medicaid patients, and then I'm going to pull in their state demographic information. And if they're not from our state, then I'm going to include it as part of our out-of-state Medicaid. Well, I mean, that's good, but that's not necessarily going to be accurate. It gets to be a little cumbersome, and there's a very high potential for it to be incorrect, because maybe it's just at registration, that was what was shown on the ID card they had, but they've already switched over to a Texas plan. So you might be lumping some of your information together. If you can keep out-of-state Medicaid its own financial class, now you're going to see the real opportunity financial impact. It keeps them from rolling out to self-pay. It keeps them from making their way all the way to bad debt. It might cause you to put a little hard stop on there, and that what we sometimes hear is, well, I usually bill at one time, and when I don't get a payment, I just go ahead and write it off to charity. So sometimes out-of-state Medicaid is lumped in with your charity care. In Georgia, the Indigent Care Trust Fund starts to hide a lot of that problem and opportunity. So you have to ask yourself the last question. If you could identify all of your out-of-state Medicaid claims correctly, what if you could get a 50% lift on that? That might be a big deal. Again, small claim volume, but high on the cash side. There's no secret that one of the reasons to that might be because a lot of your out-of-state Medicaid claims are going to come to the ER. Not all of them, and especially not in Texas with the number of children's hospitals we have and some of the really good care folks can get. But as with most things when it comes to the rev cycle, the ER is a problem. So identifying those problems in the ER could really start to plug a hole that you might not know exists. Now, before we go to our next topic of a way we're going to go through a case study, I do want to take 1 second and just say, don't be afraid to use the questions and the chat feature on the right side of the page. I'm sure if you're a regular to the DFWHC webinars, you know about that feature. That is a great spot where, as we're going through things, if you think of any question, it does not have to be related to the topic we're specifically talking about at this point in time, go ahead and type it over there so that we can have an idea of what we need to discuss either while this is going on. Dee Dee and I can move pretty quickly in and out of question and answers, or we can do them all at the end. That's fine with us as well. So don't be afraid to use that feature. And if you've got it pulled up on the right-hand side of your screen, you should see I've already thrown a chat out there. So that's one spot you can do it, or in the questions section. Now, Dee Dee, I'm going to turn it over to you, and we're going to walk through this this kind of challenge we see in the marketplace, and then we're going to help show a way in which this challenge can be it can be solved if a hospital is willing to throw enough investment at it.
Okay, thank you. The challenges in the marketplace that every facility and their staff face today is how much time and energy are you going to invest in the process of working the account. So the Argos team, we work every state, every single day, and we have the ability to have a payer-driven system, and so that gives us a huge advantage over your staff members. Perhaps your staff is very used to working with an Oklahoma claim. So that doesn't mean that just because they are presented an Oklahoma claim, you know, once or twice a month, that they're efficient at it. So what we really have to ask ourselves is how well and how much time is being spent and invested in trying to get these claims processed through. Again, it's the key of, because we see them, we're set up in teams and payer driven, these are things that we do day in, day out, every single day. We have spectacular relationships with all of the state agencies and many of the MCOs. The relationships help get claims expedited and processed through very sometimes antiquated systems. And so having a relationship where somebody can override a particular edit or something really makes a difference for us. Renewals should be handled proactively instead of reactively. We talk all the time about timely filing. However, we'll always do everything that we need to do to file your claims and protect them. But in the case of, as Kirby referred to them as one-offs, maybe you haven't been registered or active with a particular payer for 2 or 3 years. So we have to talk about the step one process then becomes the enrollment process. And that's a reactive step instead of a proactive step. Again, the enrollments we deal with for all of the payers day in and day out, and we have specialized reps that focus on only the enrollment process.
Didi, when we talk about investing in proactive, being proactive, and we talk about enrollment, et cetera, and Didi and I didn't rehearse this question that I'm about to ask her, so I hope it doesn't catch you too much off guard. But let's just take the past 5 years, maybe even to 7 years. How much change have you seen in a state-to-state enrollment process as far as, let's just say, Georgia requires this to be done this year, and by the time you came around to it again, it had changed already? Has that been happening?
It has been happening. One of the biggest things is the Affordable Care Act. The payers are now trying to keep up and maintain regulations based on the Affordable Care Act timeframes. The physician enrollment piece is one of the biggest things that has been very complicating for them. And so 2 years ago, perhaps Georgia wouldn't have required the physicians to be on file, and now they do. So that would be my example of that.
Yeah, so I just had a thought there that, I mean, while a facility may not see a Georgia claim for every couple of years, and there's a chance the same employee works for the hospital to work that claim from year 1 to year 3, they still have to learn the process at year 3 because it's probably changed based off of what the state and the federal government's requiring.
Absolutely correct.
Wow. Okay. So thanks, Didi. I'm going to roll to the next slide just a second. Let me give a little bit of an intro to it. Didi and I thought it would be a nice way to talk about what sort of investment a facility needs to put into claims in order to be successful by going through a case study. Now, when I flip the slide, you're going to see some state names in there, and you're going to see a dollar amount of the claim. I would just encourage everybody on the phone, or excuse me, on the webinar, to know that the states could be any states at all, and the dollar amount could be anything. It could be 5 million, it could be 5,000, it could be 50,000. The steps that this case study goes through can relate anywhere, anytime, any facility, any size. So Didi, I'm going to go ahead and roll to the next slide.
Okay. So this is an example of a New York facility who was contacted by a Connecticut facility. The Connecticut facility wanted to send their patient to the New York facility. They worked through that process, and indeed it occurred. The individual had been treated at that New York facility 12 previous encounters. So this was not a new patient to this facility located in New York. The stay this time ended up being a 9-month inpatient stay. And when we received the claim, as you can see, it was a $5 million claim. We immediately do what we do all of the time with each and every claim is we start at step 1, and we start by researching who's the proper payer, and what kind of authorization or notification is on file with the payer. It was at that time that we discovered that there was no authorization on file for this particular account. We reached back out to, so we billed as I mentioned, we billed the claim to the payer, as we always do, because we always, that's our number one goal, first and foremost, is we protect that timely filing limit. At that point in time, we reached out to our hospital client to see if there had been any attempts at contacting Connecticut in order to obtain an authorization. And they said that they would do some research and get back to us and let us, know something. In the meantime, then, the claim had denied by Connecticut, and it denied for lack of authorization notification at time of admission. So we went back and said, okay, it's denied now. Did you have any luck in finding anything? And lo and behold, what they told us is that they could not prove that the clinicals had been sent, but they did have a payer rep name and fax number, and that they could provide information that initial conversation had taken place. So we, that's a little bit to go on, not a lot, but it was, it was something for us to start with. We had reached out to the Connecticut retro authorization unit and tried to start a retro auth request. At that time, the payer informed us that the hospital had had 9 months to obtain and get an authorization, and that they weren't going to issue an authorization at that point in time. So we literally gathered all of the information that we could find in working with our hospital client, and we escalated this. To make a long story short, we escalated this process, and it was not an easy process, and I'm not going to tell you it only took, 15 days, because it didn't. It took some time and effort. We actually ended up getting a inpatient care manager and request to go before the board and plead our case based on that Connecticut was aware that the patient was being treated at the New York facility 12 previous times, and that it was particularly needed because it was medical necessity on the part for the outcome, for the patient's best outcome. They listened to us, we presented documentation, and it ended up being overturned by their board, and they allowed an authorization from a retro perspective to be issued, and we did end up getting this claim paid to its full reimbursement amount. So that just gives you one case study of where hours were spent in working with our client partner, in working with the payer, lots of back and forth with the payer. These are the examples of how much time are you willing to have your staff invest in things. When this is, this is what I'm trying to point out here. It could be $1 million case, it could be a $20,000 case. But because we know where to go and who those resources that we need to reach out to, we have fewer headaches than what your staff have.
And Dee Dee, I think what's really maybe to me the biggest or the most important thing about this particular case study is we aren't talking about a New York hospital that all of a sudden had a California Medicaid recipient. I mean, we're dealing with New York and Connecticut, which are right beside each other. And oftentimes what we hear is, well, I've got my border states under control. It's just the one-offs. I think sometimes the border states are causing more of a headache than we know.
That's absolutely correct. The staff at the facilities, they're most of the time they're pretty busy and overwhelmed, and they don't have, the system isn't set up to be payer specific. So even though they see often their border accounts, it doesn't mean that they're efficient, and it doesn't mean that they can keep up with all the changes. I mean, they probably have enough to keep up with just their own in-state.
Agreed. So we thought it would be nice to start to move towards wrapping things up. We're certainly not wrapping things up, but we thought to try and explain a little more about, well, what really is out-of-state Medicaid. We just thought we'd play a little true and false game. I'm going to ask the questions. We're going to attempt to stop for 15 seconds to allow everyone, maybe over in the chat feature of the webinar, you could answer what you think the answer should be. And then we'll go to Dee Dee and she'll help us with the correct answer. So let's start with, as you see, true or false. If a provider enrolls in a state's Medicaid program in order to bill an out-of-state claim, they will become an in-network provider and see an influx of Medicaid claims from that state. True or false? And let's spend 15 seconds. Everybody throw a few answers out there in that chat section. All right, we didn't get any answers, but Dee Dee, I'm gonna go ahead and roll through. Is it true or false?
So the answer to this is false. When a provider typically enrolls in an out-of-state Medicaid program, they are enrolled and on file, and they are still viewed as an out-of-network provider. However, the enrollment process is necessary for your staff going forward to secure authorizations, implement notifications, etc. So you're on file, but it doesn't mean that you're held to the same time frames as the in-network providers, and a few other varying items as well.
But Dee Dee, I think it is safe to say that there are certain states where just across the border, patients can receive just exemplary care for very, very specific things. And there are the opportunities for the provider to become a preferred provider for a certain procedure, but it's not as though you're automatically just part of the network.
That's very true. You are correct. Oftentimes, the provider will take a look and identify the, as you stated, the amount of miles that the recipients have to drive instead of crossing a border, and they'll make arrangements to consider that particular facility or facilities considered in network. They really do care about their patient population, so they will work with many facilities out there. Volume is another thing. You could be more than 50 or 100 miles from a border, but you might have excessive volume, so they'll work with those scenarios as well.
And everyone listening, this slide certainly hits home to me. I live in Augusta, Georgia, and we're about 200 yards from the state of South Carolina, only separated by the Savannah River. So we certainly have a level 1 trauma center here in Augusta, and they do see South Carolina Medicaid patients for certain specific procedures that patient just can't get close to their home in South Carolina. So the opportunity exists, but it's not just this automatic thing where all of a sudden a big influx is going to happen. All right, let's roll to our next question. True or false? If my hospital is enrolled in an out-of-state Medicaid program, but an ordering, prescribing, or referring provider on a claim is not, the claim will still pay. That's a mouthful. And let's again take 15 seconds to see if we can get a few people to throw an answer out there. Is that claim going to pay? And Dee Dee, I'm going to roll to our answer slide right now.
Okay. And just this answer is so typical when it comes to out of state, isn't it? And it does. It depends on the payer. And I know y'all get so sick of hearing that, but that's really the truth. Many plans. I'm sorry. Did something just happened? I heard something.
That's
Can y'all
okay.
hear me? Okay. I'm sorry.
You're back on.
So it does depend on who the payer is. Some of them are requiring that the attending of record be on file, and some of them are still not having that requirement implemented yet. I do believe that it will be across the board in the very near future.
Dee Dee, to expand on this one a little bit, has this become a little bit compounded and more complicated because of the MCOs involved in out-of-state Medicaid now?
It certainly has. Some of the MCO plans require that you also enroll, so that let's just say that the MCO is your payer, but they require that the payer also be on file with the state. Oftentimes they go to the state rolls for eligibility, and they go to the state rolls to determine whether or not a physician and or facility are active and participating.
Gotcha. So we had an answer that typed in true. I think true. You were right some of the time. I think it's just that could be the experience with the state you were dealing with, but the opportunity for the answer of this to be false certainly exists, and it just gets compounded and more complicated the further we go down this line of MCO involvement. So we've got one more myth and confusion, true, false. If I don't bill an out-of-state Medicaid program for a dual eligible claims deductible or coinsurance, I can still include it in my hospital's Medicare bad debt calculation. True or false? And that's a doozy. That is way down the rabbit hole. But let's take about 15 seconds to see if we can get some answers. All right, Dee Dee, I'm going to roll us through to the next one.
That answer would be false. Many Medicare provider reimbursement review boards and court decisions are very clear that you must bill before you can include these charges in your calculations. And let's not forget that that also means many, many times in order to get the bill processed and through a system to show proof that you billed and received denial, et cetera, is going to require enrollment.
Wow. So I didn't keep count, but I'm pretty sure almost every single slide we had up there, the word enrollment came up at some point.
Hey, Kirby, somebody just typed a question and said, don't they cross over? And I think they may have been referring to your last slide.
They were. I'll try to take that. They do cross over, but if you are not known, if your facility is not a known entity to where it's crossing over to, it doesn't know how to process it. Many of them reject all of the time. We see that day in and day out. Again, remember we're talking about out of state, not your typical in-state or right there, your AmeriGroup right there.
Right. That's a good answer.
Awesome. Thank you, Steve, for pulling that question in while it was relevant. That was awesome.
Well, I don't want to interrupt your presentation, but I actually am a recovering CFO, so I have a couple of questions myself, but I'll wait till you finish.
Okay, we're moving right towards Q&A soon. We've got a few more slides here. So we did want to kind of answer that last bullet point on the advertising and all the emails that went out about, does it make sense to outsource? So we thought we'd just throw out a few bullet points. Typically our clients see a 50% lift. So I think that's a pretty good increase, especially Steve, you coming from that CFO role, that might look really attractive to you. Usually what happens is with outsourcing these sorts of claims, staff doesn't go away. They just get repatriated to the better and higher reimbursing payers, the ones with more volumes, the BCBS, the Medicare Advantage plans, et cetera, et cetera. So we're not trying to replace staff. We're simply trying to keep the business office staff a little more laser focused. And then the last bullet point, when things like these claims are set up on the contingency fee basis, at least the hospital's not burning overhead on what may ultimately be a claim that does not pay. Argos Health works claims all day, every day that ultimately never end up paying. They're just some things you can't get solved. Well, for us, we burn the overhead, but the hospital doesn't have to see any of that. So those are some pretty big advantages, just those three, on why sometimes outsourcing makes sense. A little testimonial up here, and again, this is going to be available through DFWHC, so I won't spend time on the slide, but we do have a pretty good testimonial, I think, up there from Memorial Sloan Kettering Cancer Center. That's a pretty big operation over there. And then I wanted to I'll leave this up here as we go into the Q&A section. What we tried to do is break out, well, what the hospitals see before our work and what do they see after our work. And at full admission, this is a very salesy slide. So we're not trying to hide that fact. But sometimes I think breaking this out of what you might be experiencing now versus what you could experience in the future, I think that's a pretty good way to wrap things up. Do we have any other questions folks would like to ask? And maybe they were emailed in or communicated earlier before the presentation even took place.
Yeah, I'm not sure that we have any. It could be some pending, but if you don't mind, I've got a couple of questions.
Okay.
You know, hospitals today, especially in Texas, don't necessarily employ their ER docs. And so if you get out-of-state Medicaid claims that come through the emergency room, what does the facility do about the ER doc listed on the UBO form?
I can take that. Whenever possible, we try to provide the physician enrollment documents. We try to work with your credentialing department to see if there is any way possible that there is any contact information known. We don't have the answer to that because California is the same way. They don't employ their ER docs either. And so sometimes the only thing that we can do when it comes to an ER situation is establish a threshold that is reasonable for the hospital to say, okay, I'm going to take a few minutes and I'm going to invest and I'm going to get the contact information to my vendor and ask them to reach out to the physician.
So Dee Dee and Steve, wait 1 second before we have anything follow up. Dee Dee, with more and more facilities not employing that ER doc, that's a problem that's not going away.
Correct.
Okay.
You cannot, that is not an area in which you can say, I'll have the patient sign a waiver and we'll drop it to self-pay. You cannot do that. These are typically one-time visits coming through an ER. So, you know, as a hospital, there are going to be dollars in which you want to be reimbursed for.
Wow. Okay. Thank you, Dee Dee.
Another question is you look at how we're getting more and more people from out of state, especially in the North Texas, where people come because we've got some really good healthcare facilities here. How long does a facility generally have to take to get enrolled or credentialed before they can actually start billing in a state they've never billed before? Do you have an estimate on that?
Well, I can tell you that for us, typically when we start taking on bills from any facility, many times we're working in a retro environment. And so the claim is generating based on who the payer is, how we react next. Is it an MCO and they're already known and on file? Or do we have to start with square one and do we have to go to the actual state payer fee for service and then get the hospital or the hospital known to the MCO as well? Most of the time that's a two-step process because once we get the facility on file with the particular payer state, then we have to go back and start asking for things like we need to make this enrollment retro effective for prior dates of service. And we typically can get that. Some of them will allow us to go back a full year, and we have to prove medical necessity on those old dates of service like that.
Another question, I think you mentioned during the webinar, I may not have picked up on it, but you mentioned about board members and board members' information. We all understand that. But technically, aren't board members already providing information? Because if you're enrolled with Medicare, doesn't that take care of that?
it does indeed take care of that. But every payer is they're not going to accept the fact that because you're certified with Medicare and your home state Medicaid plan, they don't accept that proof. They want you to go through and sign off on the application and enrollment documents that their state has.
And Dee Dee, I think it might be worth saying that we certainly have a newer-ish client where I think we've probably been up and running now we're approaching the 3-month mark. And we've got some claims out there that will absolutely pay, but we got to get that board document submitted.
Correct. That is very
and it's a California facility, a big one, lots of charges, lots of really specialized care, but we are sitting on go until that board decides to move. And what makes us kind of bubble up as their vendor is they've already provided it, so it's not really a big deal what we're asking them to do. We've just got to get them over the hurdle that, yes, I need to provide it one more time.
Right.
They have, yeah. So oftentimes, I'm sorry, go ahead.
You go ahead. Go ahead.
I was just going to add that one of the most often asked questions of myself is, so this board of director thing, how do we get around that requirement? And I really have to look at them and just say, I'm really sorry about this. I know it's a pain and it's awful, but there is really not a way to get around it.
Right. So let me ask you, and I don't mean to ask so many questions. We're kind of watching the chat box and the question box, but while some are in process, based on y'all's experience and what you've done with this, if a hospital really is a little confused as to how large their out-of-state Medicaid population is, what would you suggest as a starting point or recommend they do?
Yeah, and so I don't mind taking that one, Dee Dee. I mean, first and foremost, I don't think I can stress enough on, I'm trying to find that slide, right here. I think what you've got to do is you've got to start to make out-of-state Medicaid its own financial class and treat it like its own payer, like you would some of the other payers that you're doing. And I'm probably in more meetings and on more calls, especially in the recent, I'd say 4 months, where a hospital knows that problem exists, but they haven't done a good job of tracking it. And I almost feel like sometimes they're scared to do it because they don't know what they don't know, and it might be a little alarming. It is alarming, but the good news is once you start to identify and track, you can solve the out-of-state Medicaid problem. So yeah, you're gonna, show some fallacies in how much charity care you had, or do we really have this much self-pay, or could we have been paid on it? Yeah, that's gonna start to bubble up, and you're gonna say, well, wow, we really didn't have that much self-pay because we could have filed all these out-of-state Medicaid, and we could have been paid if we invested the resources to actually go after the claim. But you just can't do the simple things like you maybe could some time ago of just tell me all my Medicaid folks I have that have a different state. And that's what these couple of slides were trying to stress. The world we live in is now much more transient than it's ever been. And so with that crossing the borders and the ability to travel, et cetera, I think it's something that really needs to be focused on how many true out-of-state Medicaid plans are we treating? Don't even keep up with them by state. Just keep up with them at the macro level of all these individuals had an out-of-state Medicaid plan. I'd say that's the number one way to start to solve the problem.
Right. Well, Kirby and Dee Dee, I don't see any questions pending, but I thought it would be good for you to have any closing comments you'd like.
Well, so because this is going to be available for everyone to see through DFWHC, again, I would just encourage everyone to either go to these 3 articles and start to read more into out-of-state Medicaid. these articles help to prove some of the things that we're talking about that might appear somewhat conceptual, and then start to farm through our LinkedIn page, and even set yourself up a Google keyword that says out-of-state Medicaid claims reimbursements or something like that. I would start to make it a little more of a priority to focus on not only this claim, but the four we focus on: out-of-state Medicaid, comp, VA, and then the third-party liability. There can be some serious revenue that you realize once you start to focus on it and really get these claims coming in the door as paid instead of written off. And I think there's a big opportunity out there if you just let yourself look for it. Lastly, there's Dee Dee and I's contact information. Anyone is welcome to email or call us at any point in time. You might just have a question you wanted to ask or something you wanted to verify that you're hearing. We're not afraid to take
post
any
all
of
of
those.
this. I'll let you say that. Yeah. Chris is going to make an announcement for the people on the webinar also.
Yeah, thank you, Steve. We're going to send out a copy of this PowerPoint presentation to everyone who registered, and we're also going to post. We recorded this webinar today. It will be posted online tomorrow, and we will send a link to everyone who is registered as well. So thank you.
And we want to thank Dee Dee and we want to thank Kirby. This has been very helpful, very interesting, and we appreciate Argos, and we certainly appreciate this presentation. Thank you very much.
Thank you all. I hope everyone has a great day.
Thanks.
Stay healthy. Bye-bye.
Bye-bye.